Is death always a failure of medicine? Is it a problem doctors can always fix? Is death a defeat? In our modern era, we are often led to believe so. We see medicine as a battleground. Doctors are soldiers. Diseases are the enemy. Victory is life. Defeat is death. This narrative is powerful. It is reinforced in television dramas. It is reinforced in news headlines heralding medical breakthroughs. It is reinforced in our own hopeful conversations. We have come to expect that for every ailment there is a procedure, a pill, a machine that can hold the line. When a person dies, a quiet, pervasive thought can take hold. Someone, somewhere, must have failed. This idea, that medicine ought to conquer mortality itself, has become an unspoken myth. It is a heavy burden. The power of modern medicine is undeniable. Its successes are the foundation of our high expectations. We live in an age of medical marvels. Antibiotics have turned once fatal infections into treatable conditions. Vaccines eradicated smallpox. Vaccines pushed polio to the brink of extinction. Surgeons can now transplant hearts, livers, and lungs, granting years once out of reach. A broken hip can be repaired, restoring mobility. Every day, hospital tools perform extraordinary tasks. A cardiologist threads a catheter, a stent restores flow in minutes. Chemotherapy and cell therapies can tame cancers. Dialysis sustains failed kidneys. We learn to view the body as a machine to repair or replace. With enough knowledge, technology, and resources, nearly any problem seems solvable. But success created a blind spot. Tools that save in crises can harm when misapplied to the dying. The same ventilator can save or prolong suffering without hope. For all its resilience, the human body is not a machine that can be repaired indefinitely. It is a biological organism with a natural arc of growth, maturation, decline, and cessation. We are born, we age, and we die. Medicine can intervene, often spectacularly, but it cannot halt time. Our cells have finite capacity, systems wear down. Organs lose reserve. Recovery diminishes with age. Chronic illness, heart failure, COPD, dementia, is managed, not cured. Treatments slow progression, manage symptoms, and improve quality, briefly. The trajectory is gradual decline, with crises punctuating stability. Each infection is harder. Function recovers less each time. This is the disease, not a treatment failure. In frailty, minor events cascade into immobility, infection, and rapid decline. Then medicine's role shifts. Maintain function, preserve dignity, manage suffering. Sometimes more intervention does not fight for life. It prolongs dying. Redefining success. When comfort is the cure. Sometimes death aligns with a person's values, not medical failure. Fully informed, a patient may choose comfort over cure. After grueling treatments, benefits may not outweigh pain, nausea, exhaustion. Forgoing another round to be at home, alert, with loved ones, is a valid choice. It prioritizes quality of life over quantity. Success becomes effective pain control and relieved breathlessness. Support for patients and families is central. This is palliative care and hospice. Comfort, dignity, meaning at the end of life. Machines can keep hearts beating and lungs breathing, but cannot restore consciousness or personhood. Choosing to withdraw life-sustaining treatment can be an act of love and mercy. It honors who the person was and the limits of medicine. Medicine has not failed. It has done what it could, then stepped aside. Care, compassion, truth. These become the measure of success. The myth of medical omnipotence exacts a heavy toll. On doctors and nurses, it breeds guilt, shame, and burnout. Identity built on saving can fracture when patients die. Culture's demand for miracles pressures choices at the bedside. Fearing the look of giving up, clinicians may offer long shots that prolong suffering. Another chemo, a risky surgery, not for realistic recovery, but to avoid defeat. Defensive medicine hurts everyone. Families feel confusion, guilt, regret. They ask if they did enough, if another door might have saved them. Jargon and euphemisms plant false hope and block informed decisions. It robs time to prepare and say goodbye. Delays the transition to comfort-focused care. Honest, compassionate, end-of-life communication must replace the impossible standard. Plain words open the path to humane care. To move forward, we must change the conversation. Shift from a futile war against death to a humane embrace of life. Think about what matters, long before a crisis. Talk with loved ones. It is a gift. Advanced directives and living wills are acts of empowerment. Name a trusted proxy to speak for you. Ask not only what can be done, but what should be done and what outcomes mean. Clinicians must be trained to listen, to clarify, to care. Integrate palliative and hospice earlier, alongside treatment. In the end, death is not a medical event, it is a human one. Acknowledging limits is wisdom and humility. Embrace honesty, prioritize comfort, honor wishes. A good death, peaceful, dignified, aligned with values, is not failure. It is medicine's final service. Care, compassion, truth are the ultimate triumphs.